Hi, welcome to Med Medicine with Miss P. Today I thought we would go over the antiarrhythmics and kind of plug in where they go, explain it in a way that maybe it makes sense. So like all medications, if you understand the anatomy and physiology of the body, you know where and how those medications work. Like beta adrenergic blocking agents affect the adrenergic system, right? That sympathetic nervous system. That adrenergic, as we know, is a term given to nerve endings that when stimulated release epinephrine. So you're epinephrine blocking when you give a beta blocker. So you're stopping all the things that would happen when your fight or flight sense kicks in, right? So same difference here, whether it is a GI medication, if you understand where those acids are secreted or how the colon works, you know that those medications are designed to inhibit what the body already wants to do or increase what the body is trying to do but can't. So when you understand how those medications work, you know where they plug in and how they affect the body. So when a patient is on an antidysrhythmic, I already know, or an antiarrhythmic, I already know they have an arrhythmia. They don't have to like it. They don't have to believe it. They don't have to accept it. They can be in denial. They can insist their doctor didn't explain it to them, or he never said anything like that, whatever it is. If you take 240 milligrams of Rapamil, you have a heart problem. We're not going to go through your heart to get to your blood pressure, whether it's Cardizem or Amiodarone. I had a lady yesterday, God bless her, she's like 78 years old. On the phone, she tells me she's on 80 of Lasix, 25 of Carvedilol, which she did not say Carvedilol, as we all know, twice a day, and lisinopril and metoprolol. And she doesn't think she has CHF. I said, well, what stage of kidney failure are you in? No, the doctor says my kidneys are fine. It's just from the swelling in my legs. I just skipped on over it. Like you have CHF. You also have kidney failure. 80 of Lasix. If I licked that pill, I'd pee myself right here now before I could jump over this easel, open the door, and get to the bathroom. I can't. God bless her. I blame the doctor. I don't even blame the patients. I blame the doctors. I blame the doctors and nurses for not understanding or explaining it to a patient to where they understand. 80 of Lasix, and she thinks she doesn't have a kidney problem. I can't. And for those of you that don't want to argue with me, explain it to me. Explain it to me as if I'm a 5-year-old child. Because when I get to CHF, and I will, maybe next week, or the week after. Next week is Thanksgiving, and I'm not doing a video next week. I'm sure the 6 of you will be devastated, but I'm not doing one. So we're going to talk about these meds and kind of plug them in. So I flagged these from last time we talked about the antidysrhythmics, and we're going to see if we can't make them make sense. Now that we talked about these, we'll see if we can't plug them in. So we talked about the medications before, and now we talked about the way the heart works and see if it doesn't make more sense when we talk about it. So with amiodarone, it says that it prolongs the duration of action potential and effective refractory period. And you're like, what? What does all that mean? Why can't you just use words we understand? So the action potential means it's kind of like the time it takes for the ventricles to completely fill. That action, by prolonging it, it increases its potential in cardiac output, and then extending the repolarization period or refractory, it allows the heart to relax to do it again. If you want to be very effective, you have to relax those muscles and then start again. So that's where amiodarone works right here. So you know that that's already where the problem is. It's non-competitive alpha and beta adrenergic inhibition. Increases PR and QT intervals, right? So it increases this distance and this distance. So by prolonging from the P all the way to the T, basically, because it's doing two separate paths simultaneously, you are prolonging the time it takes for the heart to completely fill and completely empty. So it's slowing it down, so it's more effective, and you're increasing your cardiac output. Decreases sinus rate, right here, right? It tells it to calm down. And decreases peripheral vascular resistance, which you would have to have if you were going to increase the stroke volume or the cardiac output. If you have a big bucket of blood, you want to throw that against a brick wall so it splashes back in your face and causes the backup? Or do you want to throw it down the long, wide open aorta that's saying, sure, bring it down, I've got plenty of time, right? Do you want to try to get it through a McDonald's straw, or do you want to get it through a coffee straw? So by decreasing peripheral vascular resistance, it's decreasing the amount of push the heart has to create against those arteries. So you know it's going to affect more than just the heart. So I flagged Atenolol, even though it's a beta blocker and that kind of works a little bit differently through the sympathetic nervous system. It makes sense the way it says it competitively blocks stimulation of beta adrenergic receptors within vascular smooth muscle. That's in those vessels, right? Prolongs negative chronotropic activity. Oh, what's that very expensive word mean? I don't know, but hey, look, it explains it to you. In parentheses, as if you don't know what the word means, it says decreases rate of SA node discharge. So it goes to the SA node and says, shh, calm down, buddy. Just relax, take a big deep breath. And by slowing that down, you know that that heart is too fast to begin with. So anybody thinking they're taking Atenolol for blood pressure, it's a heart pill. Then it says, slows conduction, increases recovery, slows conduction of AV node, decreases heart rate, negative inotropic activity, decreases O2 consumption of the myocardium, decreases action in renin-aldosterone angiotensin system at high doses. So IV at high doses, you might see a difference in the blood pressure. Otherwise, this is a heart pill. And for those of you that think you're taking it for blood pressure, I'm talking to the patients that aren't watching this, you're going to find out the hard way that by taking Atenolol for your blood pressure, you're only increasing your blood pressure because it's slowing everything down, increasing cardiac output and relaxing the heart. So what's going to compensate and start constricting to get through this change, this alteration? So, and I've seen it a lot. I've seen patients come in for surgery. They took their Atenolol that morning. Their blood pressure is skyrocketing. Their heart rate is 56 at rest. And I have to explain to them very carefully that they're on the wrong pill. And they're like, well, I took my Atenolol this morning. Yeah, I can tell your heart rate's 56. Very good. You take anything for blood pressure? No, you didn't? Well, that's the problem. And that's part of the issue. Okay, so this, I believe, is Dig. Okay, so for Digoxin, again, all you have to do is understand this, and any medication you look up will make sense. So Digoxin says it inhibits the sodium-potassium ATP pump, and that's that energy pump that's offering the energy, which makes more calcium available for contractile proteins, thereby resulting in increased cardiac output, positive inotropic effect. It literally says that in parentheses in case you don't know what increased cardiac output means. Increases force of contraction and decreases the rate. So again, it's slowing it down and then increases its ability to forcefully eject that blood. It has a negative chronotropic effect, which is decreasing the heart rate, and decreases AV conduction speed. Again, slowing the heart down so it can completely fill and completely empty, being more effective, more efficient, and thereby increasing cardiac output. And you'll see Dig in a lot of patients that, either have pre-existing conditions, AFib as well as others. My mother actually was on it because she was on so many steroids with her COPD towards the end that her resting heart rate was like 140. So while she didn't have any previous cardiac issue, we had to slow her heart down because her output was pathetic with that heart pumping as fast as it could. It never had time to completely fill and completely empty. So ergo Dig. So anybody on Digoxin, they have a rapid heart rate. Maybe not necessarily an arrhythmia, but at least a rapid heart rate, and generally an arrhythmia. You'll see it with AFib, patients that can't tolerate a calcium channel blocker because it drops their blood pressure too low. You'll see Amiodarone and Dig, which makes perfect sense, right? Here's one for Procainamide. Decreases excitability of cardiac muscle to electrical stimulate and slows conduction velocity in atrium, bundle of His, and ventricles, increasing refractory period. Right? Enough said. You know exactly where it works. You know the refractory, the repolarization, increases that time so it can completely relax. So these patients already have, for the most part, like I said, not always, but they already have a heart problem, previous MIs, maybe part of that tissue is dead and it needs to slow down and relax so it doesn't overstimulate. We had a patient, the students I took care of this gentleman for years. From what I understand, he passed, but he had heart failure. He didn't have congestive heart failure. He had heart failure, and he had everything wrong with your heart he could have. He had a history of pericarditis. He had multiple MIs, but he never really had like an abnormal rhythm. But because of the damage to his heart, we kept him on medication that kept his resting heart rate like in the 40s. And the students already, always panicked and came to me and they're like, it's 46 or it's 52. I'm like, right. We already gave you the history. Remember when I went over the history with you and I told you everything you can have wrong with your heart, he has wrong. So we want to bubble wrap that heart, put it in a rubber room, stroke its back, braid its hair. We don't want it excited at all. Because if that heart gets to pumping too quickly and is inefficient or already has so much damage that the amount of excitability it gets decreases the blood flow to that myocardium, his heart's going to stop. And he eventually, had some swelling, and as soon as that swelling started, we knew that he was getting into kind of leaning towards CHF, and eventually he did. And I don't know if that's what took him, but that was one of the things that happens with untreated or incorrectly diagnosed disorders. Okay, now this one, here, Sotalol. So the last one I have marked here, not that there's not, many others, but the last one I have marked here, Sotalol. It's a blockade of beta 1 and beta 2 receptors, lead to antidysrhythmic effect, prolongs action potential in myocardium fibers without affecting conduction, prolongs QT interval, no effects of QRST duration. So in that case, it doesn't really change this too much, but it's slowing down the heart enough. So when you see somebody on Sotalol and all your beta blockers, I know they say that, it's the chill pill for the heart. That's the way they teach you. It is, but if you know where it plugs in, then you have a little bit better idea of why this patient is on this one instead of that one. So when we get to the beta blockers, and they're not all created equally, and even if you learn them as a classification, you still kind of have to learn them individually because they work a little bit differently. So like I always say, when I get a med list, I already know what's wrong with them. In fact, at work now, we're plugging them into the computer. So when I get my med list, I can already go to those disease processes and mark yes and no for certain ones. And then I'll leave it open until I talk to the patient and go back and, correct anything that they deny or that they think they have and I didn't think they did for whatever reason, depending on the medications they're on. But when you are on 80 of Lasix, 25 of carvedilol twice a day, metoprolol and lisinopril, and, hydrochlorothiazide with your lisinopril, diazide or whatever, you have CHF. You don't have to like it. You don't have to believe it. You don't have to agree with me, but you have CHF. And not one time yet have I requested information from the cardiologist, got that information, and nowhere did it say that they didn't have CHF. Not only will they put that in there, you've got your EF, they'll do a GFR, or they'll discuss in their note the most recent BUN and creatinine, because that's what those patients have. That's just how those meds work. I'm not making it up. So that's that. I hope it makes sort of sense. I had the hardest time trying to get this easel to work with me so you didn't get a glare. I don't even know. Can you even see that? I don't know. I don't know what I'm doing. I'm so not a YouTuber. I watch a bunch and I love them to death. Some of them because I'm such a jerk. Some of them make it so hard to listen to. I don't know if you guys listen to true crime, but I listen to Molly, and she always says her name like that. Hello, if you haven't seen my face on your screen before, hello, my name is Molly. And she ends and she's young. It's not like she's an elderly lady. She's young. And then this girl I'm listening to now, she's such a beautiful girl. And she's been through so much. She was like in prison and she was like horribly abused as a child. But y'all, she says supposedly, and she doesn't say it once or twice, she says it all the time. And I understand nobody understands when it's like she and I and they and he and when to say, the correct pronouns at the correct time. But supposedly it's not even a word. It's not. And she's so sweet, but God, she is wildly, she's so illiterate. God bless her. She's so illiterate. Today I was listening to her and she was talking about this girl who's bullied when she was younger because she was so obese. You think she thinks there's a T in there? There's no T. I know, but she's beautiful and she's entertaining. And she has been through so much, so God bless her. But even I listened to this one gorgeous girl. I mean, I'm sure she's had work done, but I don't care. She's beautiful. She went to law school. She's not necessarily a lawyer. I don't know if she said for the bar, but she went to law school. And she also, God, they're like wildly illiterate. So listen, if I screw something up, you just tell me, because I got to fix that. I can't deal with that. For those of you that have had to correct me in the past, when I inadvertently said something or flat out said something wrong because I'm that dumb, just don't let it keep happening. Catch me. I can't have that. Okay, so that's it. Hey, 15 minutes. All right, that's it. Face your fears, forget your failures, follow your faith, and I'll see you in 2 weeks. Oh my God, that almost was exactly. Oop, I got to hit